Myelomeningocele, also known as spina bifida, is a neurologic condition that also affects the musculoskeletal and urologic systems. So, myelomeningocele is a complex congenital anomaly primarily affecting the nervous system with secondary involvement in the musculoskeletal and urologic systems. It is the result of a faulty embryologic development of the spinal cord. The caudal end of the neural tube fails to close before the 28th day of gestation, resulting in the myelomeningocele. Motor paralysis and sensory loss are present below the level of the myelomeningocele. The lumbar region is the most common region for it to occur. Spina bifida, the posterior vertebral arches fail to close in the midline to form a spinous process. So spina bifida is the musculoskeletal component, myelomeningocele is the neurologic component. And so when we look at spina bifida, we're looking at whether or not the neural arch of the vertebra has closed. So spina bifida occulta has no involvement of the spinal cord or the meninges, but there's failure of the vertebra to close the midline and form a spinous process. So if we were to palpate this patient, we would not feel a spinous process at the level that they had spina bifida occulta. Spina bifida cystica, which is when we have involvement of the nervous system, patients have a visible cyst protruding from the opening caused by the bony defect. And so outside of not closing the vertebral arch, we also have this protrusion of nervous system material. So in meningoceles, the cyst contains only CSF and the meninges. But in myelomeningocele, we have the malformed spinal cord present within the cyst. Etiology, there's no definitive cause for myelomeningocele. The use of folic acid in pregnancy is used to prevent it. A lack of folic acid, I guess, can be considered a cause, but there really isn't a demonstration of that per se, as much as that adding folic acid to your diet during pregnancy can help to prevent spina bifida or myelomeningocele. Prenatal diagnoses can be done with a couple different tests, and there is possible fetal surgery that can be done with the goal to decrease the need for placing a shunt for hydrocephalus upon birth. One of the issues that patients with myelomeningocele experience is the onset of hydrocephalus due to the obstruction of the flow of cerebrospinal fluid, and so they will have an AV shunt placed that drains from their brain into their abdominal region. Clinical features of MMC. So neurologic deficits and impairments include that they will present with motor and sensory impairments directly related to the level of the cyst and the level of the spinal cord defect. So this is where your dermatomes and myotomes are going to become important in remembering to help understand how the level of defect is going to impact the clinical presentation of the patient. If the nerve roots are damaged or the cord is dysplastic, the infant will have a flaccid type of motor paralysis with lack of sensation. If part of the spinal cord below the myelomeningocele is intact and has innervated muscles, the potential exists for a spastic type of motor paralysis. So we can see hypotonia or hypertonia depending on the degree of involvement of the spinal cord. And so patient presentation can differ on that. In some cases, the child may actually demonstrate an area of flaccidity at the level of the myelomeningocele with spasticity present below the flaccid muscles. And so that would basically just be cutting off innervation to the level right at the myelomeningocele, but there's still some level of innervation getting down the cord below it. Functional movement related to the level. Again, dermatomes, myotomes, important reference for this. So a patient with a myelomeningocele at T12 is going to have some control of the pelvis because of the innervation of the quadratus, and they will have complete innervation of the abdominal muscles. Above T12, they're going to have different levels of trunk control. Know that when we're looking at trunk control, we only have innervation to the level of the lesion. And so when we look at righting reactions and equilibrium reactions and trying to train those in our patients, we can only expect a response in the trunk up to the level of the lesion. Moving on to high lumbar, L1 to L2 is going to affect the lower extremities, but the hip flexors and adductors are going to remain innervated. They're unable to extend the knee actively with L1, L2. And so with the hip flexors and adductors remaining innervated, we might have normal function of those, or we might have increased spasticity, in which these patients may require stretching in the prone position. Mid-lumbar is going to be at our L3 level. These patients, the child can flex at the hips and can extend at the knees, but has no ankle or toe movement. Low lumbar, L4 to L5, the child adds the ability to flex the knees and dorsiflex the ankles, but only weakly extend the hips. At the sacral level, S1, they have weak plantar flexion for push-off and good hip abduction. To classify an S2 or S3, the child's plantar flexors must have a muscle grade of at least a 3 out of 5, so they have to be able to go against gravity, and they have to have glutes grade 4 out of 5. The lesion is considered no loss when the child has normal bowel and bladder with no lower extremity weakness. And that was starred because I would recommend you know those, understand them, know how to apply them, know what interventions might be important based on the level of the lesion. Moving on to musculoskeletal impairments. So flaccid paralysis falls to positions of comfort. So what that means is that when a patient is experiencing flaccid paralysis, they don't have any muscle activation. And so when in a position against gravity, their joints will fall to a position of comfort because they do not have the muscle integrity to hold them against any other position. So this will include putting a patient in supine, the frog leg position where the hips are abducted, externally rotated, knees flexed, and ankles plantar flexed would be the position that the child would fall into. This is a dangerous position because, especially if they don't have muscle integrity surrounding the hip, this is a position that puts a child at risk for hip dislocation. The child may have congenital musculoskeletal deformities in addition to being at risk of acquiring additional deformities because of the muscle imbalances. It may include hip dislocation, hip dysplasia, and subluxation, genu varus, and genu valgus. Congenital foot deformities associated with myelomeningeal include talipes equinovarus, which is also known as clubfoot, pes equinus, which is flatfoot, convex pes valgus, which is a rocker bottom foot. And take a look at table 7.2 for potential deformities related to musculoskeletal imbalances by lesion level. Osteoporosis is also a common clinical feature of myelomeningeal because of the decreased weight-bearing capacity of these patients. They have decreased bone density. So children with MMC are at risk of developing osteoporosis and are therefore at greater risk of developing fractures. Researchers have found that children who are household or community ambulators have higher bone mineral density than children who walk only therapeutically. Duh, because they spend more time weight-bearing, and so they have greater bone density that gets to be developed. Neuropathic fractures are also a common risk for this population. They relate to the underlying neurologic disorder. 20% of children with myelomeningeal are likely to experience neuropathic fractures, with the most common fracture in childhood occurring in the distal femur. The presence of a cast protecting a fracture is usually not an indication to certain activities in children with myelomeningeal because of the increased weight of the cast can limit their functional ability based on levels of the lesion and areas of weakness. It can also be inappropriate for positioning, even though they're not positioning for a postural deformity based on the needs of the child. It may result in a postural deformity. So being aware of the increased risk of fractures for both neuropathic and osteoporosis reasons, but also the implication in how they cannot be healed in the standard protocol. Presence of, we already just talked about that, so spinal deformities. Congenital scoliosis is related to vertebral anomalies and is inflexible. So congenital scoliosis would be scoliosis they were born with, and it is based on the way that the vertebra develop, and so it can't be fixed. Acquired scoliosis results from muscle imbalances in the trunk producing a flexible scoliosis. So when we have muscle imbalances as a result of the lesion or training or compensations, we can have a patient that develops a scoliosis throughout their growth span, and we can fix that. It is flexible. A rapid onset of scoliosis can also occur secondary to a tethered spinal cord or a condition called hydromyelia, which is basically increased cerebrospinal fluid within the spinal cord itself. Either one of those can cause rapid onset scoliosis, where basically the child is trying to alleviate pressure either from the increased cerebrospinal fluid or from the pulling of the tethered spinal cord, where it gets attached at the distal part. And that can cause pain, so they will cock to one side with an abrupt scoliotic presentation in order to alleviate that pain. Children with myelomeningeal go through puberty at a younger age than typically developing children, and this allows for earlier spinal surgery with little loss of the child's mature trunk height. but it's also important to note that those growth-related changes associated with puberty can happen earlier in this population, and so paying attention for those things as you apply interventions. Spinal alignment and potential for deformity must always be considered when one uses developmentally appropriate positions, so make sure we are always limiting the risk of postural and joint deformity. Arnold-Chiari type 2 malformations are possible coincidences with patients with myelomeningioceles, and this is where the cerebellum, medulla, and cervical part of the spinal cord get pushed down through the foramen magnum of the skull, and flow of the cerebrospinal fluid is obstructed, resulting in the patient developing hydrocephalus. And so patients with an Arnold-Chiari malformation are more susceptible to develop hydrocephalus, and therefore more likely to require a shunt placement to drain that excess cerebrospinal fluid accumulation. It may also affect the cranial nerves and brainstem function depending on the level of compression from the increased cerebrospinal fluid. So monitoring for signs of hydrocephalus is important, and we will take a look at signs of shunt obstruction here in a little bit. Hydrocephalus, you will be able to, oh look, there's my shunt malfunction. So for hydrocephalus, you'll be able to palpate the shunt tubing along the child's neck as it goes under the clavicle and down the chest wall, because it runs from the skull into the abdomen to drain the fluid. The child should avoid spending prolonged periods of time in a head down position because of the shunt and risk for hydrocephalus. We want to avoid the implications of that, and so we don't want to position them in a head down position. This can be more difficult with children than with adults because play often involves hanging upside down and those types of things, and so patient education and parent education becomes important with this one. Knowledge of signs of shunt malfunction is important. So if a patient starts demonstrating unanticipated or abnormal irritability, that is a sign of shunt malfunction. Seizures, vomiting, lethargy, or setting sun sign, which would be the way that their eyes are closing basically. Those are all going to be signs of shunt malfunction. Something is going wrong. We need to notify the supervising PT immediately, and subsequent MD call out as needed for revision of the shunt. Hydromyelia is an accumulation of cerebrospinal fluid in the central canal of the spinal cord, so it's basically hydrocephalus but within the spinal cord, not the head. And it can present with a rapidly progressing scoliosis, upper extremity weakness, and increased tone. Tethered spinal cord is the other diagnosis or complication rather that we talked about that can result in that rapidly progressing scoliosis. Because of the scarring from the surgical repair of the back lesion, adhesions can form and anchor the spinal cord at the lesion site, and so it gets stuck, and as the child grows, the nerves get tensioned. Progressive neurologic dysfunction, such as a decline in motor and sensory function, pain, or loss of previous bowel and bladder control that they had may occur in a tethered spinal cord presentation. Other signs include that rapidly progressive scoliosis, increased tone in the lower extremities, and changes in gait pattern. These patients can also have a sensory impairment. An increased potential exists for damaging the skin and underlying tissue secondary to extremes of temperature and normal pressure. And so we need to make sure that we are teaching about pressure relief, skin inspection throughout the lifespan, whether that's to the patient or to the parents or to both, because of the neurologic involvement and motor impairment that also likely corresponds to a sensory impairment. They are going to be insensate in areas that you and I are not. And so paying attention to redness, alleviating pressure spots, teaching pressure relief in all the different ways is a very important aspect of physical therapy intervention in this population. The plan of care must include teaching skin safety and inspection as well as pressure relief techniques. The family needs to be made aware of the importance of making regular skin inspection part of the daily routine. Bowel and bladder dysfunction, we may need to teach these patients to self-cath depending on the level of the lesion, which they will need sitting balance with, so hand support and the ability to do a toilet transfer in order to perform. And so looking at if they have bowel and bladder dysfunction, the types of things that we need to teach them might be different. And it is also important to note that patients with myelomeningocele are at an increased risk of developing a latex allergy, and a lot of our equipment in the therapy gym can include latex, including the use of gloves or TheraBands, so be careful that you check the chart. When treating patients with myelomeningiocyl, one of the major foci of a PT plan of care should be to minimize the impact and ongoing development of bony deformations, postural changes, and abnormal tones. Other therapeutic needs include strengthening of the upper extremities, developing sitting and standing balance, fostering locomotion, promoting self-care, encouraging safety and personal hygiene, and teaching functional mobility, pressure relief, and fostering independence. So in that first stage of physical therapy intervention, we're going to be treating them early on. And so this is going to be in the acute care where the infant receives after birth up into the time of ambulation. And so the PT is going to establish the motor and sensory level of function and determine that in the evaluation. Determine a muscle tone, degree of head and trunk control, range of motion limitations, and presence of musculoskeletal deformities. These things are going to be done typically starting in an inpatient acute setting as the child is born and it's identified early, but it can be a later onset depending on when they come to therapy. If we are seeing them immediately after, we want to make sure that we're considering post-operative positioning, avoiding pressure on the repaired area until it's healed. So remember, they've had to go in and do spinal surgery in a lot of these instances. Initially, the infant is limited to prone and side lying so that we don't place pressure on that healing site. As the back heals, the infant can experience brief periods of supine and supported upright sitting without any interference with the wound healing. With prone positioning, it's important to prevent the development of potentially deforming hip and knee flexion contractures. We've talked about this with prone positioning before. The patient can also begin to develop head control with prone positioning, and that's why tummy time is so important. And it provides a good beginning for upper extremity strengthening because they're able to weight bear through those upper extremities. So when looking at the effects of gravity, we talked about this a little bit ago. When there's no muscle tone to fight gravity, joints are going to fall into a position of comfort, and this can result in musculoskeletal deformity that can result in pain or instability in a joint or deformity throughout the skeletal system. And so we need to pay attention to the effects of gravity, make sure that we are educating parents and patients on which positions to avoid, especially based on the muscle imbalances of the child. When the infant's in a supine position, the paralyzed lower extremities will tend to assume positions of comfort. In children with partial innervation of the lower extremities, hip flexion and adduction can produce hip flexion contractures, and this can lead to hip dislocation because of the lack of muscle pull from the hip extensors or abductors to balance that contracture tightness pull out. There are certain postures that we should avoid in these patients, and that's going to include frog leg position in either prone or supine, W sitting, ring sitting, heel sitting, or cross-legged sitting, and all of that is because of the stress placed on the lower extremity joints without appropriate lower extremity muscle tone to support them. Many of these patients will have orthoses for lower extremity positioning that are used to help maintain a neutral hip, knee, and ankle position to prevent deformities. Early on, it's detrimental to adduct the hips completely because the hip joints are incompletely formed and may sublux or dislocate if they are adducted beyond neutral. And so being careful with how we position the hips and making sure that, especially if increased adductor tone is present that pulls into that scissoring position that's not safe for a child at this age because of the undeveloped acetabulum, we need to implement use of orthoses to prevent that positioning. Any orthosis should be introduced gradually because of the lack of skin sensation, and the skin should be monitored closely for breakdown. Building onto that, we want to educate on the prevention of skin breakdown by teaching skin checks and knowing that if redness persists longer than 20 minutes after donning and doffing an orthotic, the orthosis should be adjusted. There's something wrong if the redness is persisting for longer than 20 minutes. Sensory precautions include encouraging patient or parents to play with the infant and to tickle different areas of the child's body to help them understand where the baby has feeling and where they don't. The parents need to know that and understand that so they know where to be diligent for skin checks and safety for the child. Teaching the parents to keep the infant's lower extremities covered to protect the skin when the infant is crawling or creeping is extremely important. And skin that is anesthetic does not sweat and cannot conserve heat or give off heat, and therefore must be protected. And we also have to pay attention to heat tolerance with that effect based on what percentage of the patient's body can't regulate the heat that way. We need to make sure that we're performing range of motion to prevent contractures. Passive range of motion should be done 2 to 3 times a day in an infant with myelomeningeal seal. And remember, we are educating parents to be able to do those things during their daily tasks like diaper changes, bathing, playtime. Some range of motion may be done bilaterally, but range of motion of the foot and ankle should be done individually. Range of motion exercises should be done gently with your hands placed close to the child's joint to provide a short lever arm. Even in the presence of contractures, aggressive stretching is not indicated in this population. Once able, the child should be responsible for doing their own daily range of motion. So slow, static stretching is important in this patient population to avoid any injury to hypertonic muscles. And so being able to educate children on specific positions that they can maintain to get those slow static stretches as soon as they're able to understand that and take on that responsibility is important. Throughout the lifespan, we want to promote age-appropriate sensory-motor development, but very importantly, initially to build those great foundations, we want to integrate that early on. When working on the development of head control, we want to make sure that we're thinking about things like the healing of the skin over the back defect. If that's not well healed, then we need to avoid the supine positions. And when we're able to get into the supine positions, we need to be careful how long we're in there and avoiding shearing forces on the lower extremities or the trunk. The caregiver should provide extra support if the child's head is larger than normal as a result of hydrocephalus. Although head control in infants usually develops first in the prone position, it may be more difficult for an infant with myelodysplasia to lift the head from this position because of hydrocephalus and hypotonic neck and trunk muscles. And so we may need them on an inclined prone position. We may need to work them from supine instead of prone after the back defect's healed. It just depends on the patient's response. Rolling from supine to sideline with the head supported on a half roll also gives the child practice in keeping the head in line with the body during rotation around the long axis of the body. Carrying should also be seen as a therapeutic activity to promote postural control rather than a passive action. So instead of having, parents just throwing the child on the hip, having them position them outwardly with a hand underneath of their ischial tuberosities to support the pelvis, but allowing them to build that trunk control in an upright position. We also want to work the development of righting and equilibrium reactions. So head and trunk righting can be encouraged in prone by slightly shifting the infant's weight to one side of the body and seeing whether the other side shortens. That should be their response to trying to correct their head position. The extension of the infant's back and arms should be encouraged by enticing the child to reach forward from a prone position with one or both arms, and that's all just going to happen in play. Tummy time, moving toys further away from them, trying to do that joint play where they're getting in some of that mimicking and you're guiding their motions. Trunk rotation must be encouraged to support the child's transition from one posture to another. Remember, those transition movements require rotation, and so working activities that build the strength and stability through trunk rotation are important. Trunk rotation in sitting encourages the development of equilibrium reactions that bring the center of gravity back within the base of support. But remember in this population that the trunk responds only to the degree to which it is innervated. So if we have a lesion at T12, we're only going to see responses up through our trunk up to the T12 level. Everything through our lumbar spine isn't going to get a response. Moving on to trunk control, good postural alignment of the back should be maintained when the child is placed in a sitting position. So we don't want to allow them to fall into this scoliotic curve or do that sacral sitting where they rotate back on their pelvis. We want to help maintain good postural alignment. In children with good head control, sitting balance can be trained by varying the child's base of support and the amount of hand support, so slowly pulling away your support or putting them on a less stable surface. I wouldn't take them straight from the floor onto a Swiss ball and remove your hand control, but being able to back those things away can help develop the trunk support. A bench or tray placed in front of the child can provide extra support and security as confidence is gained, and a lot of times that's how we can bridge the gap to independence, so that way they don't feel like they need to hold on to you. Reaching for objects while supporting with one hand can begin in midline, and then the range can be widened as the balance improves so that we're reaching further and further outside the base of support. If the child cannot maintain an upright trunk muscularly, an orthosis may be indicated for alignment in sitting to prevent scoliosis. We want to continue to build that tolerance to upright as we have facilitated head and trunk control in order to get them to weight-bearing positions. And so acclimation to upright and weight-bearing includes sensory input to the lower extremities despite the lack of sensation. And so we may not have perceived sensation, but the brain is still able to get some kind of input from weight-bearing processes. Brief periods of weight-bearing on properly aligned lower extremities should be encouraged throughout the day. Handling should promote symmetry, which means equal weight bearing and equal sensory input. Weight bearing in the upright position provides a perfect opportunity to engage the child in cognitively appropriate play, getting them on their level of their peers and seeing what things they would interact with at that level if they were a typically developing child can help garner the right cognitive responses. Weight shifting in standing is an important pre-gait activity, and so if gait is a long-term goal of your patients, then getting them acclimated to upright standing, weight bearing, and then shifting side to side in that weight bearing position can help get them prepared for gait. The benefit of mat exercises is that we can really apply a plethora of different positions to our patient population for interventions. And so mat mobility becomes a big area for, I think, all pediatric populations, but myelomeningocele specifically because of the adaptive function that we're working on based on the level of the lesion. Supine and prone positions are important for exploring the environment and self-care activities, and so being able to work on both supine and prone activities, especially related to things that require trunk rotation like rolling, are important. We want to include movement in upright sitting, and so transitioning from supine or prone to a seated position is also an important mat activity. We need to encourage this transition to upright sitting once trunk balance has begun in supported sitting. So once we've established some of that trunk balance, we want to progress the transition for them to be able to get into an upright position independently. Children can and should use push-up blocks or other assistive devices to increase the strength of their upper extremities because they need to have strong triceps, lats, and shoulder depressors to transfer independently. And use of standing frames is often important in this population that doesn't have motor function of the lower extremities but still benefits from the sensory input of weight bearing. So by 1 year, all children with a motor level of L3 or above should be fitted with a standing frame to encourage early weight bearing. Having the child stand 4 or 5 times a day for 20 to 30 minutes seems to be manageable for most parents and demonstrates some of the best physiological benefits. The second stage of physical therapy intervention is going to be defined as the ambulatory phase. And so this is where we've gotten the patient to the developmental stage that they're ready to progress onto ambulation, provided that is appropriate for their long-term goals. And so factoring into that is going to include orthotic management and selection. The goal of an orthosis is to correct deformities that would interfere with ambulation. And so we use orthotics for patients with MMC to not only help them ambulate, but also to correct deformities that would otherwise prevent them from ambulating. We need to consider the level of the lesion, and you can see table 7.4, that's that slide that I went down as far as what we can expect for muscle activation. Table 7.4 also breaks it down into what you can expect as far as level of mobility, whether they are household ambulator, community ambulator, wheelchair level. So I would take a look at that table. And then looking at age, a child younger than 1 can be fitted with a night splint to maintain the lower extremities in proper alignment to prepare them for gait if we anticipate that ambulation is going to be one of their goals. Anticipate a child's desire to stand around 9 months of developmental age. So this isn't looking at their gestational age from when they were born to 9 months out, but rather their developmental age when they get to that 9 month of developmental motor milestones where they're able to sit independently. They're starting to pull to stand. They might be starting to cruise, but that age level, those motor milestones and level of cognitive development correlate to the standing phase for the child. And so getting a child into a stander at this phase is important. If the child doesn't attain a developmental age of 9 months by the time they are 20 to 24 months of chronologic age or gestational age, standing should be done for a physiologic benefit. So if they haven't gotten to it where they are able to pull themselves to a stand and do work on those activities by the time they're 2 years old, we need to initiate standing activities for their best physiologic benefit. Children with a high motor level should be engaged in activities to prepare them for wheelchair propulsion, such as transfers and increasing upper body strength. So if we don't anticipate gait and ambulation being part of their function, we need to prepare them for power mobility, or at least wheelchair mobility, and being able to propel a wheelchair and transfer to and from a wheelchair and those things. When we start implementing these orthoses, we want to remember that the wear schedule is important, so have them begin wearing the orthosis for 1 to 2 hours for the first few days, checking for redness, and then increasing from there, and making sure that parents and children are educated on checking for red marks and how long it takes for those marks to disappear and any other signs of skin breakdown. A couple different types of orthoses that are relevant for the myelomeningocele population include a parapodium, which isn't going to be for ambulation. It's going to be more of one of your standards. There are parapodiums that do have wheels, so you can do short distance therapeutic based ambulation, but most parapodiums are related less to the goal of gait and more to the goal of standing. Reciprocating gait orthoses can be the orthoses of choice for a child with motor function at L1 to L3. And they're essentially an HKFO or hip, knee, ankle, foot orthosis with these cables that tension and then release to help create the reciprocating leg movement necessary for gait. They're more efficient than a traditional HKFO because they use these tensioning cables to produce the motion, and they're typically introduced at about 2 years of age. They do require the use of an AD. You can't ambulate with an RGO without the use of an AD. Outside of ambulation during the second stage, we want to look at upper extremity function. 2/3 of children with myelomeningocele exhibit impaired upper limb function that can be linked to structural abnormalities of the cerebellum, and so that can also implicate our coordination. And so understanding that we need to not only strengthen upper extremities but work on coordination efforts for functional needs is important. These patients don't perform well on tests that are timed and exhibit delayed or mixed hand dominance. Children with myelomeningocele have hand weakness, poor hand function, and impaired kinesthetic awareness. The child with myelomeningocele must have sufficient upper extremity control to be able to use an assistive device. And so not only do we have their functional demands for regular upper extremity use, like brushing your teeth or eating or reaching for something from a cupboard, but we also have the need to use an assistive device for ambulation, and so we have to have sufficient control and stability of the upper extremity to maintain control of the assistive device. We're also going to look at the intellectual components for this patient because of the involvement of the brain. Cognition can be something that we work on. Visual and vision and visual perception can be something that needs to be addressed in this patient population. And they also can demonstrate something called cocktail party speech, which gives you the impression that they are able to carry on a coherent conversation and their cognition is intact, but is really just a superficial, almost rehearsed conversation that covers up their cognitive deficits. Important considerations as we progress through this stage 2, which is defined as the ambulation stage, are going to be looking at the level of ambulation. What is the realistic expectation of what we think this patient can achieve, and how are we working to get them there? Functional ambulatory level is linked to the motor level, so remember to see table 7.4. I would review that pretty thoroughly. And age changes and mobility demands are also going to factor into the level of ambulation. A child who was comfortable ambulating with an RGO and use of an assistive device at a younger age may not have felt as restricted with all of that equipment, but as they get older and their friends and peers become more mobile, they may become better equipped to be a wheelchair ambulator. And so there's somebody who either has a manual wheelchair or a power wheelchair because that gives them better social and peer interactions because they can keep up with the speed and pace of mobility. While it may be less on the functional scale from the perspective of being ambulatory or not, it's greater on the functional scale as far as participation within their community. Strength, flow, flexibility, and endurance. We want to make sure that we're monitoring joint range of motion for possible contractures, because the muscle tone imbalances can cause those potentials throughout the age range. And so even though we feel as though we have something addressed and we have activities in place, we still want to monitor for those changes. Independence and pressure relief. The more ways that are available to the child, the more likely that it will be accomplished. So teach your patients many different ways to achieve pressure relief, whether it's in a seated position, supine position, prone position, whatever the case may be. Teach them multiple ways to achieve it. Chair push-ups, forward leans, alternate positioning, all of those are great ideas. And independence in activities of daily living is going to be one of our primary goals. Delays may be the result of lower performance expectations, so we want to make sure that we're promoting the child independence. When parents don't expect their child to be able to do much, they take over and do for them. And so part of our role is to teach the child how to do for themselves, but also teach the parent how to back off and let the child do for themselves. Third stage of PT intervention, we can potentially reevaluate the ambulation potential at this point. Mobility demands change as the child ages. We talked about that with the wheelchair example just a minute ago. A previous ambulator with orthoses may be more appropriate for wheelchairs as they age for those reasons that we already discussed. If reevaluation of ambulation potential isn't necessary, or they just never achieved ambulation potential, then we can focus on wheelchair mobility to focus on positive gains of mobility and emphasize independence, because as a child ages, they get more distance from their parent. They need to be more independent in a social context, and oftentimes wheelchair mobility is the best way to achieve that. Environmental accessibility becomes important, especially when a wheelchair is an assistive device being utilized. We need to make sure that there are appropriate ramps, doorways of the appropriate width, all of those things. And then driver education with modified hand controls or modified leg controls, depending on the level of the lesion, can be something that we need to help teach our patients on how to coordinate and control, especially when they're utilizing hand controls but demonstrate upper extremity coordination deficits. Flexibility, strength, and endurance will continue to have an importance throughout the lifespan in this patient population. Prevention of contractures must be aggressively pursued during the rapid growth of adolescence, because skeletal growth can cause significant shortening of muscles. And so remembering that these patients go through puberty earlier, it is important to start being mindful of the impacts of growth spurts at an earlier age in this patient population. The low back extensors, hip and knee flexors, and the shoulder girdle are some of our most commonly implicated muscles in this patient population. In regards to hygiene, good bowel and bladder program is essential to avoid incontinence, odor, and skin irritation. Remember that depending on the level of the lesion, they may or may not have control of bowel and bladder. And so that can be part of the education that we're delivering them, is not only how to manage bowel and bladder, how to transfer to the areas they need to manage bowel and bladder, how to perform the tasks that they need to clean up, how to strengthen to be able to be independent in these tasks. So hygiene can become an important factor. Socialization, social isolation can have a negative effect on emotional and social development. And so again, trying to promote motor development that is on par with their peers as much as possible. Independent living, employment of only 25% of adults with myelomeningocele. So this is a typically rather disabled population in regards to the ability to be independent in adulthood, at least as far as financially. Oftentimes they need to live with somebody else because of the inability to get employment, and there can be a diminished quality of life that we need to educate patients on in order to help maximize their quality of life. And that comes through all of the interventions that we've talked about, as far as being able to educate them on maintaining that independence and maximizing that independence.